Welcome to the Brilliant Board Review Podcast, your trusted source for high-yield board prep and the latest in clinical medicine.
Now let's talk about anticoagulation and subclinical atrial fibrillation. You say, what is subclinical atrial fibrillation? It's noted on an EKG or some sort of device, but the patient is not symptomatic. And this is the ARTESiA trial. And basically it breaks down between Apixaban 5 milligrams BID versus ASA 81 milligrams PO daily. And they used 4,012 patients, and mean age was 76.8. That's about the age of most internal medicine and medicine patients. And 8.6% of them had a prior stroke. What did you have to do to get in the study? Patient had to be greater than 55 with or without history of stroke or TIA, with a device noting atrial fibrillation from 6 minutes to 24 hours. So one of the devices, implantable device, a Holter monitor, measured atrial fibrillation from 6 minutes to 24 hours. That was a period. And so what was noted? So if the patient had a prior stroke or TIA, the annual risk rate of stroke or systemic embolization was lower in the Apixaban group versus the ASA, significantly, 1.2% versus 3.4%. Now, if they didn't have a stroke or TIA prior, the annual rate of stroke or systemic embolization was much lower, and it was very similar between the groups. Apixaban was 0.74% versus 1.07%. Now, so it was beneficial to give Apixaban with atrial fibrillation noted on the device if they had a prior TIA or stroke, which makes sense. And this is in subclinical atrial fibrillation. Now, what is our whole purpose of anticoagulation and trying to prevent further damages from TIAs or strokes? Well, I want you to think about it in the terms of how much time, effort, and depression. If someone has a debilitating stroke and they can't wipe their butt, now think of that if that was you and you're in that bed. Would you be depressed? Would you be happy in your life that you're laying in bed and you have to have someone wipe your butt for the rest of your life? And just think of the costs to have someone or be in a facility where they have to turn you every couple hours to avoid dying from what? A sacral decubitus and having the infections related to that, aspirations, all those kind of things that happen. I want you to always think about, and you can use the terms if you like scoring, is the modified Rankin score. It measures the functional impact of life, of a patient's life after a neurological event, with 0 being no disability to 6 being dead. And then we could say 5 is severely disabled and 4 is moderately severely disabled. That's the modified Rankin scale. Now, those are things that you need to think about when you're taking care of somebody with a stroke, is you're trying to prevent them from having further damage.
Thanks for listening. Stay ahead with the latest in clinical medicine, board prep, and earn CME credits. Visit brilliantcourses.com to learn more and claim credits for this educational activity. Stay informed, stay prepared. See you next time.